Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Block 10, Cardiology in the Older Adult, Episode 2, Chest Pain. After viewing this episode, participants will review the various types of chest pain. Participants will review the causes of chest pain. Participants will review the assessment of chest pain. And finally, participants will review the pre-hospital management of chest pain.
EMS encounters chest pain in a geriatric patient quite frequently. A lot of times with the elderly, they have aches and pains and muscle pains that they attribute to possibly cardiac-related chest pain, so it gets called in that way.
The different types of cardiac-related chest pain can be broken down into myocardial ischemia, unstable angina, and aortic dissection, as well as pericardial effusion. Myocardial ischemia is chest pain that can occur with rest or with exertion. It tends to last for several minutes and classically appears as left-sided substernal chest pressure, classically with radiation to the arms or up into the neck. Unstable angina is similar to myocardial ischemia, but will last for several minutes and then resolve. Typically can occur with exertion or with rest. And there's typically a trigger. Stable angina is considered chest pain that is baseline for a patient. Typically this occurs after a set number of exertional activities that is baseline for the patient. For example, if the patient walks up 2 flights of stairs and develops chest pain on a regular basis, it is considered stable if this occurs again and resolves after rest. Aortic dissection is chest pain that occurs because of dissection of the aorta. This classically is sharp tearing chest pain that can occur between the scapula, and pericardial effusion can be somewhat more vague in terms of the character of chest pain, but patients may complain of lightheadedness or palpitations.
Non-traumatic types of chest pain can be from myocardial infarction. This often presents with left-sided chest pain or pressure with radiation. It can start with exertion or at rest. Stable and unstable angina can present similar to an MI, but symptoms will resolve. Aortic dissection is characteristic of sharp tearing pain between the scapulas.
Chest pain related to acute myocardial infarction, unstable angina, and angina are related to improper blood flow to the heart. This typically occurs because there is an obstruction or an occlusion or partial occlusion of the coronary arteries. As the heart is stressed, there can be a decrease in blood flow through the pathologic artery, causing a decrease in blood and oxygen reaching the myocardial tissue. This will cause a buildup in lactic acid, as well as a sensation of pain that may or may not be located within the chest wall. Other causes may be the increased demand on the heart not being able to, or not being met by delivery of oxygen or nutrients. This causes a buildup of lactic acid and other inflammatory agents in the heart, causing ischemic pain.
The causes of non-traumatic chest pain include insufficient blood flow to the tissues and the heart muscle. There's increased stress or demand on the heart. There's a decreased supply of oxygen and nutrients, and there's a buildup of lactic acid and other inflammatory agents.
A geriatric patient with chest pain should be approached with an increased risk of suspicion for a potential devastating cardiac event. These patients will typically have less typical symptoms of chest pain. They may not present with your classic substernal chest pain that is left-sided, radiating into the arms. It may be as vague as generalized fatigue or altered mental status, especially as our patient population ages. They may have underlying pathology that may prevent them from presenting with classic clinical symptoms, or they may not recall these because of dementia. For this reason, all patients that present with potential cardiac disease should be fully assessed for any sort of underlying cardiac pathology. Once again, this includes taking a history, performing a full physical exam of the heart, lungs, and general perfusion of the body, and an EKG should be obtained on all of these patients.
It's important to perform a full assessment on all cardiac patients to make sure that you're covering all the bases and that it's not a respiratory problem as opposed to a cardiac problem. You want to make sure that you do a good BLS assessment and assess vital signs, and then do a good ALS assessment, and then do a good HPI and make sure that you ask questions about their history and what's been going on the last few days, so that you have a good overall picture and you can make appropriate diagnosis, or actually the appropriate decisions on what your treatment course will be.
Every patient with chest pain should initially have their airway, breathing, and circulation assessed. We should look at their general appearance, place them on a cardiac monitor, and obtain an EKG. The heart should be assessed for any potential signs of pathology. The heart should be auscultated, and any pathologic heartbeat should be noted in the EMS report and communicated to the accepting provider. In addition, the lungs should be listened to assess for any signs of heart failure. We should look for jugular vein distension as well as any other peripheral signs of decreased perfusion, such as diaphoresis, wet, cool, or clammy skin, or decreased capillary refill. It is important to perform a full cardiac assessment in all patients with cardiac complaints, because patients can present with a wide variety of symptoms. In addition to this, all symptoms do not occur from one single pathologic cause. The chest pain may truly be cardiac related, it may be pulmonary related, or it may be GI related. For this reason, it's important for us to have an understanding of the character of pain in order to build a differential diagnosis and treat these patients properly.
Some atypical presentations of acute AMI or ACS may or may not involve chest pain, may or may not involve dizziness, syncope, shortness of breath, nausea, vomiting. It's not always presented as the classic chest pain. So we want to make sure that we don't just look for the well-known stuff and keep in mind that we have some other possibilities that may have caused a problem with the heart.
A provider should have a high index of suspicion for older adults with chest pain. Older adults can present with more mild symptoms. All patients should receive a full cardiac assessment, which includes inspection and auscultation of the chest and lungs, a good set of vitals, sample history, and history of presenting illness, or an HPI. Finally, providers should obtain an EKG and consider a 12 lead.
Managing a geriatric patient with chest pain may be a little bit different in that they don't really feel pain or may not feel pain as a younger person will. So it's kind of suspect when they say they have 2 out of 10 chest pain. On the average individual, that might actually be like a 5 or a 6 or maybe an 8 out of 10 chest pain. And on the other hand, they may actually be hypersensitive to pain, and a small amount will be a very big amount for them. The biggest thing that you want to do when you have somebody that's in the geriatric population is you want to make sure that you just maintain a high index of suspicion that they may have a cardiac event going on, and you want to make sure that you are not kind of blowing off a low-end complaint as something that might actually turn out to be a little bit more. Field treatment for a AMI is going to revolve around doing a very good basic assessment, a good ALS assessment. You want to check out your HPI, and then you do 12 lead EKG. Make sure that you give your aspirin, your nitroglycerin as needed according to protocols, and then transport to the hospital. Aspirin administration for Monroe-Livingston Regional EMS is recently went to the level where basics can give aspirin. So as an ALS provider, whether you're on an ambulance or on a flight car, you may or may not have to give aspirin at this point. Aspirin is given very early on for acute chest pain calls or chest pain calls because it can actually help stop the clotting of anything that's going on. It's not going to break up a clot, but it's going to help stop it very quickly on. That's why BLS are now doing it, and when you give it, you want to make sure obviously that the patient doesn't have an allergy to aspirin, and then you want to have them give 324 milligrams of baby aspirin preferably, and make sure the patient chews it up so that it can be activated in the system as quickly as possible.
The management of chest pain begins with having a high index of suspicion. Providers should give supplemental oxygen, aspirin, which should be 324 milligrams of a regular baby aspirin chewed, nitroglycerin, and morphine. Providers should also give a timely transport. After viewing this episode, participants will review the various types of chest pain. Participants will review the causes of chest pain. Participants will review the assessment of chest pain. And finally, participants will review the pre-hospital management of chest pain.